you
You're not distressing me.
do.
Okay, we are live now. We are live now. Good evening, friends. Namaste. It is indeed a special milestone celebration today as we are about to open our 25th episode of Diabetes Bytes in the company of a few good men and women. RSSDI Diabetes Bytes started 25 weeks ago as a vision of our president, Dr. Banshi Saboo, and Secretariat holding Dr. Sanjay Agarwal, and the entire executive committee's encouragement as a social connect initiative from the RSSDI social media team consisting of 6 core members. It has been our constant endeavor to bring all our past presidents, patrons, EC members, senior KOLs, state chapter office bearers, our oration awardees, and the list goes on to all of you. The sole reason was to educate the public on different aspects of diabetes and also to make you all aware of RSSDI as an organization and also all of its activities. Without further ado, let me welcome our eminent guests for the evening to discuss an extremely empathy evoking topic of diabetes distress. Before I hand over to Dr. Rajiv, who's our moderator for this evening, let me welcome Dr. Banshi Saboo. And has Dr. Sanjay Agarwal joined in?
No.
Dr. Banshi Saboo, please, we would love a few words from you on the 25th episode of Diabetes Bites.
So, first of all, thanks, Purvi. And this is our 25th episode of RSSDI Byte, which is a social media initiative. And I must thank all the member of this RSSDI social media team, which is Dr. Purvi, Dr. Shalini Jaggi, Dr. Pratap, so many more who are the part of it. The primary idea of doing this RSSDI social media Byte is on Facebook because we want to increase the awareness for diabetes and at the same time RSSDI. We all know that RSSDI is one of the biggest organization in our country who is having professionals who are working for diabetes. So primarily the purpose of this social media Byte is to increase the awareness about diabetes and how we can prevent diabetes. Today's topic is very, very interesting, and Dr. Rajiv is going to moderate. We have two eminent experts from our country, Dr. Sanjay Kalra, who is immediate past president of Endocrine Society of India. He was also the past executive member of our RSSDI from North India, city of Karnal. And we have eminent endocrinologist and diabetologist from city of Pune, Dr. Unnikrishnan. So, Dr. Rajiv Kovil is an eminent diabetologist of Mumbai, who is a active member of RSSDI Maharashtra chapter. And next year we have RSSDI at Mumbai, where he is an active organizing member of RSSDI Maharashtra. So with these few words, Rajiv is going to moderate this session, which is very important session, diabetes distress. As we know, all know that as soon as someone is diagnosed with diabetes, for few days to few months, and some of the patients even up to few years, they don't accept that they have become diabetes, and they always have a distress because of that. And today we were talking about the Happy Diabetes Clinic and Happy Metabolic Care Center. You know, Sanjay had written that chapter on an M3 India page that how to make our clinic happy. You know, the primary idea is a person who is having diabetes, his distress is to be significantly reduced. And to have it, I mean, how it can be done on a social media platform, because we want to increase the awareness of happy diabetes clinic or to decrease the diabetes distress. We have two eminent speaker and one very eminent moderator. Over to now, Dr. Rajiv.
Thank you, Banshi. Thank you, Purvi, and a fantastic initiative from the RSSDI social media wing to kind of get into a penetration across pan India for patients. It's very important that patients are our end consumer and they should get benefit from whatever organization and whatever kind of scientific advantages or scientific leaves or revolutions we get. And thank you, Dr. Kalra and Dr. Unnikrishnan, for being here. So before we start rolling, the first thing that a patient actually gets into as soon as he develops diabetes is he suspects the lab. He thinks that there's something wrong in the lab and he wants to recheck his report and goes to another lab. And this keeps on occurring where he's in denial for very long. Dr. Kalra, what exactly is diabetes distress? I mean, how will one and when does it come in? It comes with diagnosis. Is it with diabetes, or is it with the regimented lifestyle, or which comes with diabetes? Over to you, Dr. Kalra.
Thanks a lot, Dr. Rajiv. And this is a very important question. Now, when we look at the word distress, it comes from the word stress, right? And stress is an emotion. It's a normal part of life. So all of us experience stress in daily living. In our daily life, we can get stressed out due to various reasons. However, it's the reaction to stress which defines our health and well-being. Normal. We might say that some people can cope better with stress, others cannot cope with stress. But still, all said and done, no matter how much philosophy we talk about, living with diabetes can be stressful, especially when something new is foisted upon you. So, if somebody suddenly develops diabetes, or somebody suddenly develops a complication of diabetes, or somebody is suddenly prescribed a particular treatment regimen, which can be related to drugs, which can be related to lifestyle, or this will cause stress. How do we define diabetes stress? It's a very simple definition. If there is extreme, note the word extreme. If there is extreme apprehension, discomfort, or dejection. So maybe as an individual, I am diagnosed to have a particular disease. I suddenly begin feeling afraid, or I become discomforted, or I become sad. That is diabetes distress. But there has to be a reason for this. And that's what Dr. Rajiv is actually asking about. If I perceive that I am unable to cope with the challenges and demands of living with diabetes. So as a person with diabetes, suddenly I cope with life ahead of me. All the things that the doctor is going to tell me to do, all the things that the dietitian is going to tell me to do. And this makes me extremely apprehensive. It puts me in discomfort, or it makes me dejected. That's diabetes distress. So after all this long definition, suddenly we realize that all of us go through distress.
Actually,
those of us living with diabetes or with complications of diabetes may have distress every now and then, but you will label it as diabetes distress only if it is extreme, an extreme emotion, and if it is related to a fear of not being able to cope. So all said and done, it's a coping disorder that we are talking about.
thank you. Thank you so much, Dr. Kalra. Dr. Unnikrishnan, in your practice over the last few decades, diabetes distress, are there certain individuals who are more prone to it? Like, are the younger people more prone to it, or the elderlies or type 1s are more prone, and type 2 diabetes? Do you see any differences in them that, is also personality driven? What do you feel, Doctor?
So I first of all thank you for having me here, and I feel that the ability of a person to cope with diabetes is not just only that person's issue. In my practice, what I've seen is that where the family is very supportive, where the community is very supportive, where the society or the people around that person are warm and friendly and helpful, I think that's one area, one situation where I think diabetes distress is likely to be rare. But where the person is left alone, remember, diabetes can be very challenging because you have to, people with diabetes have to face these daily challenges every day. They have to face it at the breakfast table, at the lunch table, at the dinner table. They have to feel the guilt of not exercising, of not checking their sugars, of missing their medication. So all this becomes much more bearable and helpful if you have a community around you that is there to take care of you, and at least if not to directly take care of you, for the patient to know that yes, there is somebody around me to take care. It could be the community, it could be the medical team, it could be the diabetes educator, it could be the family. So I think that's one area where I find that diabetes, the role of the family, and rightfully, I think it was a few years ago, one of our International Diabetes Association, and of course the WHO also has highlighted the role of the family and its importance in diabetes. But it's not just about the family and blood relatives and all that. It's also about the community in which you live, the society at large, whether the environment is obesogenic. So that's my personal. If I were asked to pick up one factor, it would be loneliness as a factor increasing diabetes distress, and a good community around the person, helpful community as a factor which will protect against diabetes distress. Though there are several other factors.
So fantastic, Dr. Tony. So a family which eats together, a family which cooks together, would obviously, if somebody gets diabetes, he will be able to better cope. We always tell patients that there's nothing like a diabetic diet. It's a healthy diet for the whole family. So if if in a family somebody says you're a diabetic, you can't eat that, that itself would add to a distress. Dr. Kalra, this diabetes distress and depression, how would a patient be able to differentiate, and how do you think a doctor would be able to differentiate whether he's going into depression of this impending doom feeling, and or whether it's a coping problem? Do you think that one can differentiate between the two?
This is important, and we should be able to differentiate not only doctors, but caregivers, family members, and also the person living with diabetes himself or herself. Now, diabetes distress is an emotional response. So you have to understand that diabetes distress is normal to a certain extent. It's only when it becomes extreme that it may be called a disease. But depression, on the other hand, is a specific disease. It's a psychiatric condition which has specific clinical diagnostic criteria. So if you wake up in the morning feeling sad, feeling down, and that happens almost every day, if you stop enjoying life, you're not able to see anything happy in life, that may be depression.
Okay.
In diabetes distress, however, there will be a very clear-cut reason. The reason is, like I said, a diagnosis of diabetes, a diagnosis of a diabetes complication, a sudden addition or starting of a treatment regimen, or maybe a self-monitoring regimen. Like your doctor tells you, you have to check your sugar 7 times a day. Or a sudden change in this. Like you've been taking 4 insulin injections every day and life was fine. Now suddenly the doctor says you have to take 5 injections a day. Or you've been going to the kidney doctor regularly. Now the kidney doctor says, we may have to go in for dialysis. That's a sudden change. It's a big change. So these kind of reasons are there which will precipitate distress. Secondly, in distress, the distress will be related only to life with diabetes or to a particular aspect of diabetes. Otherwise, the person will be fine. He will not be depressed when he or she is speaking with loved ones. He will not be depressed at work. So that's how it's easy to make out. The challenge, however, Dr. Rajiv, is that when we use the word depression in colloquial language, in English or in Hindi or Marathi, then we use it in many ways. Like, I just might wake up and say, I'm feeling depressed today. So feeling depressed doesn't mean that I have a major depressive disorder. So sure. I'd like to share a few things with everybody. In Hindi, in our philosophy, it is said that you never know when. Also, whatever you think may convert into whatever you say. That always happens. and whatever you say may actually convert into action. So what I would very humbly like to share with everyone is think positive and speak positive. So never say that you are depressed, because 99% of the time you are not in major depressive disorder. You're just saying it just for the sake of saying it. So why don't you say, I am challenged today. There are challenges in front of me today, but I am going to overcome. If I can overcome on my own, that's fine. Otherwise, I will take help from a loved one, maybe a family member, maybe somebody at work. If I can't find a friend or a colleague to help me out, I'll go to the doctor. The doctor will help me out. Suppose the doctor is not able to help me. Like maybe I've got a new kind of insulin from USA, and maybe Dr. Unikrishnan doesn't know what is in that drug. He will phone a friend and he will find out. So I will find support for myself. So the first thing we are sharing is think positive, speak positive. And like we said, never know when Mother Saraswati will be on your tongue. When you speak positively, actually positive things will accrue to you. You will actually find positivity around you. Number two, find support. And at the most, you will see that support will be 1 or 2 steps away. So let us say, for example, I want to know how to become a member of RSSDI. Most probably what will happen is I will phone Dr. Rajiv or Dr. Banshi and they will tell me how to become a member. That's one step. Suppose my question is, I want to join the social media team of RSSDI as a volunteer. At the most, it will be 2 steps. I will contact Dr. Banshi. Dr. Banshi will put me in touch with Dr. Purvi. Dr. Purvi will help me. So that's a 2-step support that I've got. And at the most, it can become 3 steps. It's not going to go beyond that. So think happy, speak happy, and you will actually find that there will be no distress in life.
Fantastic, Dr. Kalra. You actually allayed the fear of a lot of people who must be actually listening to it. A lot of people during this pandemic have also got, on top of diabetes, COVID-induced distress. So I think a lot of distress is going on, and 2020 is something that we all would love to forget. Over to you, Dr. Unni. In diabetes distress, is there some way that healthcare professionals can actually diagnose or score or kind of find out whether they are doing better? Is there a prognostic scoring system or something like that, that one can actually find out that how this patient was mild and has now gone on to become severely in distress, or whether he has come down with the kind of helping hand we gave him? So is there any that kind of a score or a scale or anything like that?
So, what the American, for example, if you look, just take the it is recommended that periodically we screen our patients for depressive symptoms. Particularly, it could be once a year, once in 2 years, and that could be a standard, the scoring systems and the standard DSM criteria. But there are additional times at which we as doctors should be mindful, and we should be to a patient's possibility of being depressed or having a stage of diabetes distress which they are not able to handle. That's when there is a medical issue, and second, when there is a change in their circumstances of their life. Let me give you an example. One issue would be, as you mentioned, the lockdown and lockdown-related particular job insecurity. That could be one lifestyle change in life parameters which could for looking for a diabetes distress or a depressive mood. And an example of a medical problem which causes distress, and patients thinking that, oh, this is too much, ये मेरे से नहीं हो सकता, इतना करना है, blood sugar checking और ग्लूकोमीटर से चेक करना, इंसुलिन लेना, दवाई लेना, परहेज करना, व्यायाम करना, ये सब मेरे से होने वाला ही नहीं है. That kind of feeling of, I can't do this, that feeling comes whenever they're stuck with a diabetes related complication. That's the commonest, that is one situation where there is a change in medical status. And one particular area where I find patients are really distressed is in diabetic foot disease. When diabetes affects the feet, that's when, when they get burning pain, tingling, or when they get an injury or an infection, that's when they become particularly vulnerable to changes in mood. So yes, we as doctors should be mindful that Of course, in addition to periodic screening, we should also reassess our patients whenever there is a change in their life status or whenever there is a change in their medical status. If we think about these three things, and always, I think whenever we talk to our patients using pleasant, good, positive language uh, wherever possible, not only wherever possible, always using a positive language to the patient, making them feel happy and cheering up. They spend a few minutes in our cabin, and if we can use that little bit of time to, put a little bit of inspiration in them, I think that will go a long way in allaying diabetes distress.
Thank you so much, Onni. Dr. Kalra, a few clinical situations, which do you think adds more to the distress? Like you also spoke that when a patient requires to do an SMBG, as against when the patient is started on insulin, or maybe when you break a news to him that probably he's got chronic kidney disease or he's progressing in his retinal problem. Which one do you think is difficult for the patient to cope with, or it's also based on inter-individual personalities and how they cope with this? So and like when we start insulin, the patient feels that the doctor is punishing me because I have not done well, or I have not followed up with him. So which do you think is a bigger clinical picture in day-to-day lives of patients?
Thanks, Dr. Rajiv. This varies a lot from patient to patient, but let me continue the discussion that Dr. Uni Krishnan has started. So, when you are screening for mental health, the easiest way of screening, and this message is for all the healthcare professionals and everybody who is attending this webinar, there are many methods of screening for mental health. But the simplest method is something called Hooley. The name of the lady who found these two questions, her name is Dr. Hooley, Whooley. Hooley's two-item questionnaire. So what Dr. Hooley says is, ask two questions to yourself, ask two questions to your patient. And if you have a positive answer for either of these, that means you may need more evaluation for mental health. Just and these two questions are, during the past feeling best or feeling hopeless? And the second question is, during the past month, have you often been bothered by little interest or pleasure in doing things? So note the word past month, note the word often, and then been bothered. Is this bothering you? If it's not bothering you, then we move ahead. And then this is 10 day, like doing things all over, all throughout the day, everything. So this Hooley's questionnaire helps us identify whom to focus more on, whom not to focus on. The other thing that Dr. Uni positively to each other as well. If we do this, we can actually allay distress even before it starts. But still, there are red flags in the life of a person with diabetes where we have to be more careful. The first is when diabetes is diagnosed. So that day may be a heavy day for that patient, especially if on that very day the doctor tells you that you have to take insulin. So one is the diagnosis of diabetes. The second is the diagnosis of any complication. And like Dr. Rajiv said, it can be an eye complication, it can be a kidney complication, a heart complication. In general, if these complications are going to be managed by tablets, the distress is not too much. If you're going to advise injectable treatment, which may be insulin, which may be GLP-1 receptor analogs, which may be an injection like maybe like low molecular weight heparin, that increases the level of distress. And if a treatment is like maybe an angiography, an angioplasty, or maybe dialysis, or maybe a surgery for the foot, then that increases the distress manifold. So these are the red flags that we have to focus upon. But it's nice to see this discussion going forward, and I'd like to thank Dr. Purvi also for describing our discussion in such a nice manner. Dr. Purvi, really hats off to you. We've been discussing all over the world, Dr. Uni and I, and you've been able to compress this into 20 minutes. into short sentences and phrases which make it very easy to understand. So if you take a problem statement, we can now talk about solution statements. We can actually talk about solutions to diabetes distress. So that is the nicest thing of all this.
Very true. Very true. I think extremely well coined discussion. Dr. Unni, in terms of how do we sensitize our whole clinic, our staff towards diabetes distress? Very often it's our staff, which probably is the educator or dietitian or whoever takes history, that, oh, you have this is a problem. Oh, you have this you have this is a problem. So it's very important that our whole clinic staff is very receptive. They understand. There's a lot of empathy among them, and that itself could go a long way in allaying the distress that comes with it. So what according to you would be the first stage of kind of reducing the distress in these patients, when they reach your clinic?
So I think the first point of contact is always the reception. Where a patient walks into a hospital, it is the reception. And the reception team should be always told to not just be empathetic, also be sensitive to patients who are ill. Because patients who are ill are not patients who are always cheerful. They may be upset, they may be worried, they may be anxious. So people in the hospital will have that extra step to be kind, gentle, and even a smile at a little bit of criticism. Second thing is the atmosphere of the clinic. We could talk about diabetes-friendly hospital. So what we've tried to do is that to keep the seating warm, friendly, and cheerful with good colors around you. That keeps calmness to the mind. The third thing is that always from your staff to the senior most doctor, non-judgmental. In other words, we are not here to judge the patient. We are here to listen and solve. So the importance of this is because when a person with diabetes goes to a dietitian, he or she's already feeling a little guilty. And if you reinforce that guilt by asking about, do you have sweets? Do you have this? So that really brings a defense or a wall between the healthcare provider and the person. So I think appearing non-judgmental and truly remaining non-judgmental, because who are we to judge why a person is not, to judge that a person is at fault for not following diet and exercise. There could be 1,000 factors why a person with diabetes is not able to follow that. If we as doctors tomorrow, if we have diabetes, we might be in the same situation. So that feeling of empathy is important, because only when you realize that, then we will be able to solve the why of diabetes. We of course know how diabetes, how diabetes comes. It's because the insulin isn't working or the insulin isn't produced and the glucose goes up, etc. But I think it's important to go into the why, and that when you look at that why, it's not simple disease biology. It's about the environment, the society, the individual behavior, and of course the person's history that has brought him to our doorstep with diabetes. So I think right from that to the time when the person leaves the hospital on a cheerful note, with a prescription or advice, lifestyle change advice, in which every doubt is clarified and cleared, and you have they have a smile on their face. I think that's what we should aim for. It's not always possible, but I think it's good to keep that as an ideal.
Thank you, Uni. Dr. Kalda, would you like to add on that? Yeah, Bansi, yeah, please go ahead.
So sorry, मैं in between कुछ बात कर रहा हूँ. संजय, बहुत important बात है और इसको मैं लोकल हिंदी लैंग्वेज में बताना चाहूंगा. Sometimes हम पेशेंट को एक बाजू बहुत चीयरफुल रखना चाहते हैं, और सेकेंड टाइम ऑल्सो वी ऑल्सो वांट टू टेल द पेशेंट दैट ए अनकंट्रोल्ड डायबिटीज विल लीड टू कॉम्प्लिकेशन. नाउ ये एक बहुत ही डिफिकल्ट है. वन साइड वी वांट टू कीप द पर्सन वेरी चीयरफुल. वी डोंट वांट टू टेल हिम दैट डायबिटीज कैन क्रिएट सो मेनी प्रॉब्लम्स, एंड we want to create an environment where we have a lot of empathy with a person, and now we don't call them a patient, rather a person with diabetes. And other side, at the same time, who is keeping his sugar all the time under control. Since last 10 years, his sugar is never under control. He's not regular in his monitoring. His A1C is always high. And he had developed already some of the complication, or already he had microalbuminia or early retinopathy. So other side, we are also training our educators, nutritionists to talk about the diet. We are always talking to them that please tell the patients about the regular monitoring and self-monitoring and getting the complication screened. Otherwise, they will develop a lot of complication. So it's very difficult situation, for a clinician also. कि एक बाजू पेशेंट को आपको खुश रखना है that you want a very happy diabetes environment and happy diabetes clinic, and other side we also want to keep a eye on their complication and talking all the time them कि बहुत अच्छा control करो, that's very important, and that also increases the stress because this happens even in our clinic also. We are seeing a lot of patient 50 60 and a lot of dietitian and educator, and then two of the patients come आके बोलते हैं साहब आपके एजुकेटर ने तो मेरे को बहुत डरा दिया, यदि मेरा सब कुछ कंट्रोल नहीं होगा तो क्या मेरी आंख चली जाएगी. So it is very very difficult, as he was telling me कि भाई सभी अपने एजुकेटर को डाइटिशियन को अपन को अच्छा एजुकेट करना है. तो मैं जिस फिजिशियन या क्लिनिशियन एंड डायबिटोलॉजिस्ट से आपको पूछता हूँ कि ये इसको बीच में कैसे रखा जाए.
So Dr. Banshi, so this is actually why diabetes care is very difficult. For all the doctors who are listening, you have algorithms for ICUs, you have algorithms for ICCUs, you have algorithms for neurology care units, and those algorithms are quite easy to follow. In diabetes, however, you have more algorithms than the number of people living with diabetes in the world. If there are, let us say, 300 million people living with diabetes in the whole world, there will be 300 million different types of management strategies going on right now. So that is the challenge. Living with diabetes is tough. Caring for people living with diabetes is tough. But we have a framework for the challenge that Dr. Banshi Saboo has just pointed out. And also we have a framework to help explain what Dr. Unikrishnan very smilingly said at the end. It's not always possible to do this. We call this the insulin framework. So let me take insulin initiation. Fulcrum, you know what it means. You have a seesaw kind of a thing where children play with each other. So at some time one child is on top, at another time the other child is on top. The seesaw that we play with in the OPD is biomedical versus psychosocial. So this is again speaking to everybody who is listening. You look at the biomedical challenges, you look at the psychosocial challenges, you look at the possibility of biomedical complications, you look at the possibility of psychosocial complications. Now, today I had a patient in my OPD, a 15-year-old boy. He has been diagnosed to have diabetes for the past 6 months. HbA1c is 21.4. The lab was kind enough to give the exact value. Thank God they didn't give 21.43. Ketones large. Child came in acidosis. We advised insulin. We hadn't even advised admission to him. And the family walked out. It was quite clear from their body language that I was not the first doctor who was advising insulin. So there will be people like that. Now, in this particular scenario, the risk of biomedical complication, the risk is death. So if you have a person where there's a life-threatening, limb-threatening, organ-threatening, like kidney, liver, heart, or sight, SIGHT, sight-threatening situation, then we have to advise insulin and we have to advise it firmly. Of course, you cannot put the patient in chains or in fistcuffs and then admit him, but still you have to be very firm. If the patient leaves your clinic and goes to seek a second opinion, so be it. Your karma is to give good advice. That is what you have done. Do not be rude, do not be judgmental, but be firm. So to this patient we said, beta, to the boy I said, you need insulin, it will help you become better. To the parents I said, I understand that you are trying your best for your child, but this is the best. You can try your luck elsewhere. On the other hand, there will be people where there is no immediate life-threatening, limb-threatening, organ-threatening, or sight-threatening situation. In such people, don't be in a hurry to prescribe insulin. Advise insulin, tell them the advantages, call them back early. Don't give a follow-up of 3 months. So let us say, today again in my OPD, I had a 55-year-old gentleman, otherwise doing fine, HbA1c 9.3. He's already on 4 oral drugs. I know that he needs insulin, but there's no immediate threat to life. So what I did, I just changed the trade names slightly because already the previous physician had given a very optimal prescription. I changed the timing of the drugs, maybe from immediately after I made it 10 minutes before the meal. And then I told him, why don't you come back after 5 days? We'll speak more about insulin. Why don't you think about insulin? On the prescription, the cue was that my educator also has to speak about insulin. So she also spoke about insulin to him. And just in passing, in very casual, because she had the pens lying on her table, she showed him, these are different kinds of pens, Uncle ji. It's very easy to use them. Don't worry too much, I'll help you. So we just counseled the patient, primed him, and sent him back. So this insulin fulcrum, what I'm saying, it's biomedical versus psychosocial. Now this helps many doctors in the audience now suddenly realize I had been getting frustrated and getting angry at so many of my patients all these years. Now at least I can reduce my anger and frustration to maybe 20%, because 80% of those patients, they don't have any immediate life or health threatening issue. All we are doing is call them back quickly. There's a psychology behind this as well, and that is called Prochaska's theory of motivation. So when the patient comes to you, he or she is in pre-contemplation. Just put the patient in contemplation, let the patient think. And it's not that we're doing any hi-fi rocket science. We do the same thing at home. Supposing today Dr. Banshi Saboo wants to buy a Mercedes, he will not just say today I want to buy a Mercedes and he'll go and buy it. At home they will discuss a lot about, should we buy a Mercedes, should we buy an Audi. Dr. Unni and I, we will talk about Nanos and Maruti 800s. And then finally, after some time, after discussing about that, then we'll go and buy it. And the contemplation part, it's fun actually. Because when Dr. Purvi has to buy jewelry for herself, then also the contemplation period is quite long. What kind of jewelry do we buy? Do we buy it from Tanishq, or do we buy it from maybe from Dubai maybe? So the longer the contemplation, the more the fun, and the more the chances that you will adhere to the therapy. Otherwise, even when we go back to cars and jewelry, supposing we buy without contemplation, we just buy on the spur of the moment. As soon as we come back home, the first thing that is going to hit us is post-purchase regret. And that is what happens to your patient also. You force insulin upon the patient, or you force a new glucometer, or maybe you force bariatric surgery upon the patient. The patient might listen to you, but the next week he is going to go into post-purchase regret. And let me assure you, the moment post-purchase regret comes, the patient finds a new shop to purchase the next time. So he is not going to adhere to therapy. He is not going to adhere to the therapist as well. So this fulcrum has helped me learn a lot. And let me speak about Professor Jubin Jacob from Ludhiana. Dr. Jubin Jacob has created a very nice model, three-dimensional kind of a model, where he puts green and red and amber. And he's able to describe, what kind of patients you will be green with, like they have to take insulin. Others you will be amber, so you follow Prochaska's theory. And others will be red. You just talk about insulin. You may need insulin in the future, but right now you're doing well on tabs. So when the time comes, we'll see. But if you follow diet and exercise properly, this honeymoon will last. So Dr. Jubin's model is very nice actually to go through.
Dr. Kalra, fantastic. I was learning, and all four of us were in awe of this. We could have just kept on continuing this. Fantastic. To be very frank, fantastic. Now the scenario when the patient comes to the clinic, the first point of contact is going to be the educator. Now, as you said, as Bansi also said, the many a time the educator tells the patient कि आप अगर ये नहीं करोगे तो आँख खराब हो जाएगा, पैर कट जाएगा, ये कट जाएगा, वो कट. So, are there any specific treatment modules for diabetes distress? Should there be some prescription drugs to be given if suppose patient is not able to cope with it, or it is just hand holding and psychosocial? I think
Dr.
both of
Unni,
you all could answer that.
Dr. Unni first.
Yes.
So I think many years ago, I don't know if Dr. Sanjay remembers, we wrote an article about diabetes treatment by the ear.
Yes.
So I think that's one of the key things, that the management of diabetes therapy by the ear is based on 4 pillars. One is to strengthen the patient's self-care skills. Second is, so that's by inspiring them and telling them you can do it and hand-holding them. The second is optimize their coping skills to situations. Third is to minimize. Change can always be difficult. Change from diet and exercise to pills, or change from pills to insulin, or a physical activity regimen can always be difficult. But you can always minimize the change-related discomfort. And the fourth point is utilization of uh, uh, external support. And it all comes down to, if you look at each person's anxiety levels. Somebody may have absolutely no anxiety. They may be completely laid back and may have inertia. That's the patient you'll have to goad into action, that you need to follow your diet, you need to follow your exercise. Then there's a sweet spot where patients have a reasonable amount of, self, self responsibility, and they are self-realized and are at ease with themselves, and they can manage their lifestyle very well. On the other end is the extreme, which we refer to as diabetes, extreme diabetes distress, where there is a panic, and those patients, we'll have to really calm them down and offer them help and support. So maybe Dr. Sanjay can talk a little bit more about this diabetes therapy by the ear. But I think also listening to the patient, that's probably the most important thing. I don't believe in giving medicines for diabetes distress. I believe in giving as much supportive care as possible as a doctor. Over to Dr. Sanjay.
Yes, Dr. Kalra. Yeah.
Thank you, Unni, for this point. Actually, when we coined the term, diabetes therapy by the ear, and when we began sharing this with our colleagues, the response was quite variable. Actually, it was fun also. In meetings, when we would ask people, doctors, what is diabetes therapy by the ear? So Dr. Rajiv and Dr. Banshi and Dr. Purvi, everybody elder to me would immediately say counseling, education, therapeutic patient counseling. And everybody younger to Unni Krishnan and me would say, such and such a company is developing insulin ear drops. Or they are going to check glucose through the ear, through the auricular blood. So these are the kind of responses we would get. But diabetes therapy by the ear basically has three pillars. Number one, listen to your patient. Listen the way you would want to be listened to yourself. Speak with your patient. Speak the way, as softly as possible, the way you would want to be spoken to yourself. Use your ears like a stethoscope. And number three, filter your patient's ears from unwanted noise. So if your patient is being bombarded with WhatsApp and social media messages, which tell him that insulin is bad for health, which tell him that diabetes can be cured by following such and such an alternative diet, then we have to explain to the patient. Now, many times the patient comes to us and says, can I take such and such an Ayurvedic medicine? They have promised to cure me. Or the patient actually comes and says, I stopped your insulin 3 months ago, and I began taking this alternative medicine, and now my sugars are fine. But the way to approach it is, I understand that you to get good health, but it hasn't worked. See, the person who advised you this medication, he doesn't even know how to measure glucose. He has never been able to create a glucometer in the past 5,000 years. So if you cannot measure glucose, how can you treat glucose? So this is the way to handle. But the first sentence will always be positive. I know that you want good health. I know that you have tried your best. But now let's go and do the proper thing. And Dr. So only I've forgotten, but there is this Italian painter who was maybe Leonardo da Vinci or somebody. Can you find out who it was? He made a nice painting, and a shoemaker criticized him because in the painting the sandal or the shoe was not painted properly. The painter said, yes, thank you for helping me, and he actually changed the painting. Then what the shoemaker did, the shoemaker kept on criticizing other aspects of the painting, and this was a very famous painter. And then the answer of the painter was, shoemaker, don't go further. So your domain is the shoe, so just stick to the shoe. Similarly, taking inspiration from that particular Italian painter and the shoemaker story, what I tell my patients is, see, if you want to get your shoe fixed, you will go to a shoemaker. Supposing you have a silk shawl or you have a silk sari and you want to get it stitched, maybe it got torn slightly, then you will go to a tailor. Both the tailor and the shoemaker, they both have a sui dhaga. They both have a needle and thread, but that doesn't mean that they can do each other's work. So let's help you take care of your glucose. And this kind of an approach, this is called diabetes therapy by the ear. The four pillars also that Dr. Unni spoke of, let me repeat them again. In terms of diabetes distress, number one, strengthen the self-care skills of the patient in terms of diet, how to do physical activity, how to monitor, how to inject yourself. Number two, minimize the discomfort associated with change. Any kind of change will have discomfort. So just do it one at a time. Today, maybe I will teach insulin technique. Tomorrow, I can teach self-monitoring. Or today, I will teach insulin and self-monitoring. I can get the kidney test done next week if it's not urgent. Number three, optimize coping skills. So this is called coping skills training. Learn how to accept the challenge, be optimistic, begin planning, and then go into action. And number four, help the patient find other support. The support may come from within your healthcare system, from yourself, from the educator, but find people in the family, in the community, who will be willing to help. So, for example, yoga. Now, in North India, in most temples, there will be free yoga classes going on every morning. Many places have free meditation centers. And Dr. Unni is an expert on Indian innovations for glucose control. So Dr. Unni will talk to us about the evidence that he uncovered. But who've done quite well in yoga classes because they became more disciplined. So you tell your other patient also, why don't you join that class? You will find more friends. So helping people find support is another way of diabetes therapy by the ear.
Fantastic, Dr. Kalra. Now, moving on, a lot of patients require doctors who are accessible to them before they come to doctors. And once we give them an advice, the first thing they do is Google it up. So, do you think that, if we could have an AI-based kind of a web app where, patients have these hundreds of questions? Can I eat honey? How much should I exercise? Should I go on a salt-restricted meal? Can my insulin damage my kidneys? So all these things, the questions and the cobwebs in their mind, could a AI based app help them? Do you think that that could be the future, where we could give them an app and which does not have a physical person but an AI and keeps on answering them? Would that be a solution in future? Do you think so?
Thank you. Okay.
Yeah,
so, well, I think that AI is definitely here to stay, but I'm a firm believer in the traditional methods of history taking, examination, and talking to the patient. Now, AI is going to develop to a point where it is going to be as close to the human empathy and intelligence as possible. That's called the point, the scientists call it the point of singularity. But that's a long, long way ahead. That day might come, it may never come. But for the moment, I think it's all about traditional good history and examination. But I'd like to add one area where AI could help. AI could help both doctors and patients in making decisions, to make complex decisions simple. Whether, for example, this patient person, I think I shouldn't even be using the word patient, I should be saying person with diabetes. Is this person with diabetes suited for a particular diet, say a low carb diet or a lower carbohydrate diet, or another form of diet? So this thing, AI could be a useful tool in deciding, and in that sense, a good doctor or a good doctor who has AI-based decision-making support is probably better than a good doctor who does not have that support. So that way, AI may give a little edge to a doctor's decision-making. But the key is that you have to be a good doctor, but like Dr. Sanjay said, and we all agree, listen to the patient and take them along the road from diabetes distress to a life without stress. And I think the key word is words of comfort. I think Dr. Sanjay and me, we also wrote about this in an editorial. just if there's one take-home message, it's words of comfort. A word of comfort will go a long way in person with diabetes. Person with diabetes at every stage of diabetes.
Dr. Unni and I would like to acknowledge the source of this concept, words of comfort. It comes from a Malayali author called Dr. Abraham Verghese. So Dr. Abraham Verghese is Indian descent and he did MBBS from Madras College. His book Cutting for Stone talks very eloquently about this, about the importance of words of comfort and about therapy by the ear. And this book by Abraham Verghese has actually helped us shape discourse regarding diabetes care in our country. So that is our source. Artificial intelligence is important. We now have situations where people can get diabetes coaching, obesity coaching, and this is important. So there are many companies. One good example is a company called Fitterfly, where you get an app and you have a coach who is in regular touch with you. In the app, you fill in what you're eating, what you're not eating, what happens to your glucose values, whether you're exercising or not exercising, again, what happens to your glucose values. And your coach talks with you not only about the content of behavioral modification, which would be diet and exercise, stress management, sleep hygiene, and substance abuse, 5 things, but also in general about an approach to life. So these kind of things will help in the future. And we will have diabetes therapy by the ear. It's just that instead of having a face-to-face contact, it may be supplemented with, it cannot be totally replaced by, it may be supplemented with remote connection. One example, Dr. Rajiv and Dr. Purvi, is what we are doing right now. We are speaking with colleagues from across the country, from across the world. We may not be face-to-face, but still we are connected. And Dr. Purvi's words are so nice. I mean, she's able to compress everything into short sentences. So that connection is there. It's just that it's not face-to-face, but still it's an important connection.
Absolutely right, Dr. Kalra and Dr. I think we have the last 5 to 6 minutes, and I would like both of you all to conclude to patients as well as doctors, to doctors, that how they can be more empathetical to their patients and probably handhold them in the initial few years, and especially when you add on an injectable or break a bad news to them. And to patients also, that diabetes is a chronic illness and you need to it's a long road, and as far as you're on the right road, you're not going to get a complication. So a concluding remark from both of y'all before I hand it over to Dr. Purvi Chawla and Dr. Banshi Saboo. Dr. Unni, you to start off first.
Dr. Rajiv, if it's okay with you, I'd like to come in just for a minute.
Please come in.
Okay, so this discussion has been so very interesting. It was compelling, that I wanted to ask you this, and all three of you or all four of you can jump in with what your experience has been. Do you feel that women have more vulnerability to diabetes distress as compared to men? And if so, then what is the vulnerable age group for them, or it's not something that you see in the clinic?
As the moderator, can I go in first here?
Yes,
I personally think yes, because you are saying so, it's clicking in my mind that I personally think yes, that women probably have a lot of responsibilities at home and if they are working also, and probably diabetes adds on to the whole jhadu kapda, the whole rigmarole that they go through. So since you just said that, it also clicks in my mind that yes, probably it's women who go through more distress than men. Over to Dr. Kalra and Dr. Unni. Your feedback on this.
Well, my view is also that probably women have diabetes distress, and that's because of non-biological factors, if you like. Because of the patriarchy that is embedded in the society, women are at higher risk of lot of diseases. They are, first of all, there are studies to say that women present late. For example, if you take myocardial infarction or heart disease, which is a complication of diabetes, women present late to hospitals. They present in a more sicker condition to hospitals. And I think it's important to recognize that this is a societal issue, and we as doctors should be aware of it. And wherever possible, we should try to put in efforts to see that this is taken care of. The other point is also that when women present to there also, Dr. Purvi is here. There is also a study published, very interesting study, which says that women doctors treating persons do much better than men doctors, because not just because of the knowledge and ability, it's also empathy, reliability, sincerity. So there are studies to say that when women are doctors, and this is for in the field of cardiovascular disease and cardiovascular events, that they do much better than men. So I think this is a non-biological issue, and more power to women and doctors, and also people with diabetes. I think we need to be sensitive, and we need to make sure that women come for follow-up on time and are brought early, because a lady's job is always perceived to be sacrificed. That's not true. I think women need to come to hospital, and they need to be given the priority that they have been sadly denied because of the societal attitude, and this needs to change. Over to Dr. Kalra for his views.
I agree with you there, and I think even cardiovascular studies have shown that the use of antihypertensives is much more in male patients as compared to women. So obviously that the whole aspect of us being a patriarchal society, I think that definitely drives that point further. And I completely agree with you when you say women physicians probably have better outcomes in a lot of chronic conditions. Um, and I think one more thing is I'm a bit confused with the feedback that both of you have given so far, that women have more diabetes distress, because I also firmly believe that women have better coping skills than men do. So,
That's also true.
Yeah, I think the correct sentence would be that women have more stress on their shoulders, but they are able to cope well with it.
Yes,
So
yes,
they have the stress of taking care of themselves and of the family members. Even if a child develops diabetes, there is more burden upon the mother than upon the father. So that's true. Uh, from a gender
so
perspective,
women do better as far as diabetes distress is concerned. Women do better than men, and there's no doubt about that point that you made.
but they
regarding
definitely feel it more also. Okay, so that
regarding
clarifies.
women in diabetes, number one, regarding women who are living with diabetes, to all diabetes care professionals, remember to take a history of pruritus vulvae. Even if you are living in a part of the country where it is difficult to speak with patients about this, there are many soft ways of doing it. So when you're taking a history, don't jump into do you have irritation or do you have pruritus in the genital area? That is not a very polite way of asking. So you can say, how are you doing? Do you have any skin lesion? This is non-threatening. Do you have any itching over the body? Again, non-threatening. Then the second question is, Madam, while passing urine, do you have pain? Now, this is slightly more threatening. After that, Madam, any other irritation anywhere else in the body? Maybe in the ladies' tract. So this is translated into Hindi, ladies wali jagah pe. So this is my way of asking. Now, from a non-threatening to a threatening way, you've gone in a very slow and very sober manner. And at least in our part of the country, the main driver for people coming to the OPD is symptoms. So this is a very common symptom which you can uncover. And if you don't uncover it, you can give as much insulin as you want, as many OADs as you want, you will never be able to get control until you treat the underlying infection. So that's one. Another thing is sexual dysfunction. So as a male provider, you may not wish to talk about it yourself, but please empower your nurses and educators to do that. In my clinic, I still struggle. I'm on the wrong side of 50 now, and I feel uncomfortable. Many times we have to ask girls a menstrual history, and the culture doesn't allow me to do that. So my receptionist does that for me very quietly. And the menstrual history comes to me written on a piece of paper. There is a condition known as vulvodynia, and I would like to call this out for all healthcare professionals. Dynia means pain. Vulvodynia is quite common. It's more common than you think it is. And this is a form of peripheral neuropathy. The same way that you would treat a diabetic painful neuropathy, vulvodynia is to be treated in the same manner. So just try to ask these questions. If you can do it yourself, fine. If you can't do it yourself, find a team member to do that. So that was about women living with diabetes. Regarding women who manage diabetes, there is a term known as compassion fatigue. So even doctors, we get tired and we get frustrated speaking with patients in positive language, trying to motivate them to follow good behavior, good lifestyle, and we get fatigued at times. But even Mother Teresa understood the value of compassion fatigue, and she would send her nuns on sabbaticals every few years. So the concept of fighting compassion fatigue, this we should learn from the fairer sex, from women. And it would be good to have more interactions where we can learn coping skills from our lady colleagues, and that will help us. As a closing remark from my side, I would like to share a best practice that I have, and the inspiration for this comes actually from Dr. Banshi Saboo. This is my best practice. This is a paperweight which lies on my table, and if you can see, listen to learn, learn to listen. So this is on my side. It keeps on reminding me what I am there for. Also, there is another side to this, so I can rotate. Speak to serve. Whenever I am speaking in my clinic, I am serving my patient. I studied in a college called Christian Medical College, Ludhiana. The motto of our college is, my work is for a king. So when I am speaking to serve, I am serving my patient, but my patient is my king. It's a higher authority. So I speak to serve, and I serve to speak. And like I already said, how do I listen? I should use my ears like a stethoscope, like an effective stethoscope. I should listen such that others love to speak to me. I should listen such that others love to speak to me. And how should I speak? I should speak such that others love to listen to me. So this paperweight is what reminds me to practice diabetes therapy by the ear. And why I said we are inspired by Dr. Banshi Saboo, because Dr. Banshi Saboo actually does it. He doesn't say it in English, but he actually does this. So that's it. And I'm sure Dr. Purvi and Dr. Rajiv, you will agree with me that
I'll agree with you. I'll agree with you.
Dr. Uni Krishnan, but for the
Only
final,
your concluding remark before we
Absolutely.
hand it over to.
Well, I'd like to quote Kabir here. ऐसी बानी बोलिए मन का आपा खोए औरों को शीतल करे आपहु शीतल होए. So let's speak in such a way that we are able to calm the
Wow.
other person. Not only do we calm the person sitting across us, that has a calming effect on us. And the individual is part of the society, and that means the whole world will become a calmer place. So on that note, let's do better for our patients and reduce diabetes distress.
I'm sure a lot of people who have listened
Great.
to both of you the last hour, I think their distress has surely come down. And I'm sure if this goes on YouTube, there'll be a lot of followers on YouTube. Thank you so much. Thank you, both of you. Let me hand it over to Dr. Purvi, and Dr. Amit Gupta is also here, and to Bansi to conclude the session. Thank you so much.
Yes. Welcome, Amit. He's the pillar of our team, the social media team. And I think with that, we'll request Dr. Banshi Saboo to give us his final words also on this topic, and then we'll close.
First of all, I enjoyed thoroughly the discussion between Dr. Sanjay Kalra, Unni, and Rajiv. And the last message of Kabir Vani from Dr. Unni, that was real great. As we were talking about the diabetes distress, but I think this subject requires Purvi few more episodes on diabetes bites, because that is what I think. And we may take few more doctors across the country who can talk on diabetes and distress, because this is very important. Again, from North India, as Sanjay was talking about some of the terms, which is more difficult in his part of reason where how he has to talk. in the Pune, then we can understand that how South Indians and how East India, how they deal with this type of distress situation also. So that will be good because we have now more than 10,000 followers from all across the country. Person with diabetes, family members, lay person, as well as the doctors who are following Diabetes Bytes. And once again, thanks to all two eminent speakers of our today's program, along with moderator Dr. Rajiv Kovil. And thanks to our social media team, Purvi and Amit is already there. So thanks to both of them. And now I hand over to uh, Amit first for a few words, and then Purvi will close the session. Thank you.
Dr. Amit
Thank
is a pillar of Haryana as well. We have exported him to the rest of India.
you.
It's nice to see him. And Dr. Purvi, if once your turn comes, if you could acknowledge all the people who are commenting on Facebook Live. For example, Dr. Abhijit has just commented. If you could acknowledge them later after Dr. Amit has spoken.
Abhijit, Dr. Sunil Kota, they are always following us. So next time,
Yes,
Sunil, I am going to invite
Dr.
for the
Ashutosh
program.
Sharma, Dr. Bhushan Midda, and Manish Kumar Jangam, all of them. Thank you so much for this following and the comments that you shared. It's very encouraging for us to keep bringing new episodes. Amit, please, before we finally
Thank
close.
uh, and it was really a very, very nice episode. And Dr. Sanjay Kalra sir and Dr. Unni Krishnan again highlights the role of passionate and compassionate care, sir. So the care is not just about giving the medications, as rightly said by you. It has much broader perspective. And with your words of wisdom, I am sure that our viewers will definitely benefit. And this episode will be available for repeat viewership again on YouTube as well as the Facebook page of RSSDI. So next time, whenever you want to discuss about diabetes distress, you can simply share the link with your patients as well, and they will definitely benefit by listening to this talk. What I do is that I play all the episodes of Diabetes Bites in my center every day. So every day the patients are learning some new things, which all the experts from the India they are giving to us. So this is really a Bhagavad Gita of diabetes, which the with the efforts of Dr. Banshi Saboo is getting created on the website or the handle of the RSSDI. Thank you, sir. Thank you for your kind words. Thank you very much, sir.
I agree completely, Amit. It's been a great resource for us to play in our waiting rooms while the patients, are there waiting to see us. So thank you all again once for that. And on behalf of the entire RSSDI social media team, Amit and myself extend a heartfelt thanks to Dr. Sanjay Kalra, Dr. A.G. Unnikrishnan, and Dr. Rajiv Kovil for a very different topic, something that appears to have only psychosocial implications, but from your detailed discussion we all learned not just the intricate theories behind it, the principles of underlying the same, and the vulnerable times in the life cycle of a person with diabetes, and then managing it or coping with it. And of course the philosophical touch that you all gave and the spiritual innuendos thrown again were again with in tandem with the scientific technicalities, was absolutely fantastic and eye opening for us and for many more, I'm sure. Dr. Rajiv, your moderation was excellent because you brought out all the finer aspects also of diabetes distress, which is seemingly very simple to deal with. So thank you once again for this amazing engagement and for your time and your effort in making all of us more aware of this aspect of dealing with diabetes and making us better professionals for the sake of our patients. Thank you so
Thank
much.
you.
Thank you.
Thank
Thank
you.
Thank
you.
you.
Thank you all.
Thank you,
Thank you,
everyone.
Purvi.
Thank you all.
Thank you, Dr. Banshi.
Thank
Bye
you, sir.
bye.
Thank you.
Thank
Thanks,
you.
Sanjay.
Bye.
Thanks, Unni. Thanks,
Bye.
Rajiv.
Thank
Have
you.
a
Bye.
lovely
Always.
So
end
should
of
we
the
wait
year.
for another 10 seconds before it ends?
Okay.
Yes.
Yes.
Yes, the video should be great.